Hello everyone, welcome to Module 3 of the Simpler Training module. Before using the Simpler tool, there are certain steps you need to go through before applying the tool. Basically, the tool is there to help you investigate the reason patient is not achieving the glycemic, blood pressure, or cholesterol targets. The first thing that we should be doing is to get a medical and social history of the patient. And then we go through the allergy, the current or traditional medications. The laboratory results is next, and then ask about the hypoglycemia-like symptoms. The compliance assessment, for example, using a adherence tool, patient's knowledge of the dose, frequency, indication, and timing of the dose, and using the Simpler tool then to make an intervention. So let's look at an example. This patient, named Agatha, is a 59-year-old lady diagnosed with type 2 diabetes 6 years ago. Her mother has diabetes and died of myocardial infarction. She works as a part-time clerk in office and does volunteering work for local aged care facility. During her pastime, she also does some gardening and also housework. She sometimes forgets to take her medication. She stops taking when having cold symptoms. Otherwise, she's compliant. In the past, since the last visit, she had 3 hypoglycemia-like events. Her exercise is about 15 minutes every week. By the way, she's already sought advice from a dietitian, but only follows it sometimes. So let's look at her pathology report. Her full blood count is normal. HbA1c is 8.2%. Fasting blood glucose is also elevated, 10.3 millimoles per liter. Her lipid profile, triglyceride is elevated, not achieving the target. Creatine clearance is fine. Her urine albumin to creatinine ratio is 5 milligram, so it is more than the 3.5 milligram per millimole, which means microalbuminuria. Her blood pressure is great. Her BMI is actually increased. She should be 23. Waist circumference is also increased. It should be 80 centimeters. However, the other lab parameters are normal. Her current medications include metformin, glycoside MR, pioglitazone, telmisartan, amlodipine, as well as rosuvastatin. So these are the questions that we need to be asking ourselves. What is the target for LDL, TG, triglyceride in Malaysian diabetes guideline? So if any of you have the answer. Yes, for LDL, it should be less than 2.6 if they don't have any other complications, and triglyceride should be less than 1.7. The next question is, do you routinely monitor cholesterol targets? It's usually 6 to 12 weekly. HbA1c needs to be monitored every 3 months. But of course, sometimes in some facilities, we don't have the budget, so it could take a yearly test. But of course, the patient is welcome to go to Path Lab or any other private facility to be tested. Bearing in mind, HbA1c is accurate if it's done every 3 months. The third question is, what treatment intervention would you make if LDL and TG levels are not on target, especially for Agatha? So it would be a statin, for example, simvastatin 20 milligram. So when do you suggest initiating statin? So remember the indicators in the Simpler tool. So there is the indicator that states it should be initiated in patients more than 40 years with or without cardiovascular disease. For patients with cardiovascular disease, The target LDL is 1.8 millimole per liter or less. Okay, now let's look at the blood glucose management. So what is the target for fasting and 2 hours postprandial blood glucose according to diabetes guideline? Just shout out if you have the answers. 4.4 to 7 for fasting and 4.4 to 8.5 if it's 2 hours postprandial. So when do you suggest initiating insulin? So insulin initiation if glycemic control is not achieved despite being on 2 or more oral hypoglycemic agents. Okay, let's go to the third question. Which type of insulin would you start? In the beginning, you would start, yes, basal or premixed insulin. How do you increase the dose and what are the intervals? It's 2 to 4 units every 3 to 7 days. So what is the target HbA1c for this patient, especially for blood glucose management? So we need to aim a reduction of HbA1c by at least 1% to get a less than 7% HbA1c. But of course, HbA1c is individualized to each patient, depending on whether they're elderly or whether they're young or whether they have diabetes for 5 years or 10 years or whether they have multiple other comorbidities. Second question, what is the prescribing indication for metformin? Yes, metformin should be continued and started if it's not contraindicated. So third question, what problems due to oral glucose lowering drug and insulin do you encounter among your patients? Hypoglycemia. Yes, also causes of hypoglycemia in this patient. So it could be due to diet or timing of the doses, for example. So how do you manage hypoglycemia? We use something called the rule of 15 and manage the causes of hypoglycemia. So for example, some patients, they experience hypoglycemia in the early mornings, and the reason being sometimes they skip dinner or they eat very little dinner, and that causes the early morning hypoglycemia. Of course, there's the dawn phenomenon as well as the Somoki effect. You can always Google them. Okay, these are the rule of 15. So always, when you have the symptoms of hypoglycemia, check your blood glucose level. If it's below 3.9, then it's time to take 3 teaspoons of sugar, like the white sugar, or 15 grams of honey, for example, or 3 glucose tablets, or 3 sweets to come up with 15 grams. And then wait for 15 minutes and recheck your blood glucose again. And if your blood glucose is above 4, then just see whether your next meal is at 15 minutes away. If your next meal is more than 15 minutes away, then have something to eat like a sandwich, for example, while waiting for your next meal. Or if your next meal is within 15 minutes, then just wait for your next meal. So let's say when you test again your glucose level, the first time you wait for 15 minutes, you take 15 grams of sugar and you wait for 15 minutes and you test, and now it's actually still less than 3.9, then again repeat the same thing. Take 3 teaspoons of sugar or 3 teaspoons of honey, 15 grams of honey, or 3 sweets. Alternatively, if you cannot swallow 15 grams of carbohydrates, you can always administer 1 vial of glucagon IM intramuscular, which has to be done in the clinic. Measure glucose after 15 minutes, and if it's more than 4, test again after 1 hour. So how do you monitor medication assessment? So we've come to M. So of course you use the validated medication adherence tool like the MCQ or the MyMart. So how do you identify medication-related problems? Yes, did I hear anyone say use the validated simpler tool? So how do you solve the problem for this patient? So in this patient, the patient was having hypoglycemia and not achieving the blood glucose target. So what we can do, there are a few alternatives that we can do. Number one, we can reduce the glycoside dose to 90 milligram daily, or we can stop pure glitazone, reduce glycoside dose to 90 milligram daily, and add empagliflozin 10 milligram OD. And then stop rosuvastatin, because rosuvastatin can increase your blood glucose level, so we can change it to simvastatin 20 milligram daily. To solve compliance issue, because she says she sometimes forgets, we can always suggest a combination of two medications to ease the adherence, to smoothen and facilitate her adherence. For example, vildagliptin 50 milligram and metformin 1000 milligram perhaps, or prendopril 4 milligram and indapamide 1.25 milligram if they're taking two antihypertensives, valsartan 160 milligram and amlodipine 10 milligram perhaps. Okay, this is just some of the examples, not for this patient, but just some examples of taking combination medication. Next, we come to blood pressure control. What is the blood pressure target according to guideline? According to recent ADA guideline, yes, this is the target stated here. Number two, which antihypertensive is strongly recommended for diabetes in the absence of contraindications? Yes, I'm sure most of you got it right. Is ACE inhibitor or ARB. What is the daily salt limit intake for patients with hypertension? Yes, 5 grams daily or 1 teaspoon. Next, we're coming to L for lifestyle. So let me ask you this question. When you make an intervention on diet, do you refer to any tools or guideline? Because the guideline that I refer to is the CPG MOH diabetes guideline, which actually talks about the local food and delicacy, and it tells you what carbohydrate counting it has. Also, I usually follow the plate model, but for some patients do ask me how much fruit they should be able to take, so I actually show them how much they can take according to the carbohydrate content. So I've been told by the dietitian that for fruit intake, you should only take twice a day. So for example, you can have a fruit in the morning and afternoon, or afternoon and at night, and it should be just one slice according to the carbohydrate count. So you can actually look it up in the CPG guideline. Okay, next question. What does the guideline recommend on exercise? Refers to CPG guideline. So yes, 150 minutes per week minimum. What is the target for BMI and waist circumference according to the guidelines? Yes, less than 23 for BMI, and also less than 80 centimeters in women. What other lifestyle interventions should be made in a diabetes patient? So this is where you refer to the simpler tool under L. And this is what it is: smoking cessation, alcohol intake, stress, foot care, and erectile dysfunction. Okay, under simpler for R, cardiovascular disease risk factor. Number one, when would you recommend aspirin as prevention strategy? Again, refer to the simpler tool under R. So aspirin therapy is not recommended as primary prevention to decrease cardiovascular disease risk. So we need to achieve targets for BP and cholesterol. And again, the ADA 2023 recommends to have a discussion with patient before initiating aspirin if the 10-year risk is more than 10%. So basically, does the benefit outweigh the risk of bleeding? This is what we need to ask and have a discussion with the patient. Lastly, we need to calculate the Framingham risk calculator. So I actually did this with some of my patients, and you can actually look at their reaction when I told them that because they reduce HbA1c, therefore their risk of getting cardiovascular disease has also reduced. So they were really, really pleased and happy to listen to this news. So it's good to discuss and have a discussion about this. So a link for the most suitable Framingham risk calculator is available on the important web pages document, which is also posted in the classroom. So that is the end of module 3. Again, if you have any questions, please do not forget to post them in the Google Classroom itself, and I'll get back to you as soon as possible. Thank you once again.